I would like to start off by thanking Dr. Jackson for being a fabulous mentor, for allowing me to run into her office at any given moment to help me with all of my problems and helping to review my paper as she was traveling cross country. So thank you for everything that you've done, Dr. Jackson. This wouldn't have been possible without you. So this morning I'll be discussing recreative music therapy and improving verbal communication skills in children with Down syndrome, which is a topic that is very near and dear to me. So to start off though, I know music therapy is not a common career that people hear about. There's only about 7,000 music therapists in the world itself. So music therapy is a process-oriented intervention in which the therapist engages the client in active music experiences that help to improve specific problems that interfere with the client's realizing the full potential of daily functioning. Within that, so music therapy is a helping profession. We as music therapists strive to help our clients to achieve and empower and encourage them to receive the best possible life that they can attain with their each individual abilities. We work with infants all the way through hospice care in any setting that you can imagine. And we do this through the innate and instinctual elements of music that can connect to people in ways that nothing else can. And it's through those relationships that are formed between therapist and client and through the music is facilitating those relationships that we are able to bring about true healing and improvement of life through different health. Within music therapy, there are 4 methods of how we use music within treatment. And those 4 methods, within those 4 methods, there's an infinite amount of possibilities of how music can then be used to create the different experiences. For the purpose of my study, I was looking specifically at the recreative method of music therapy. Recreative music therapy experiences are when the therapist and client are singing or playing pre-composed music together in songs. So in the sessions, the music was pre-composed by either another musician or by the therapist herself. And then they are actively engaged in the music making, whether that's through singing or through playing an instrument, or both. I chose this topic for many reasons. One of the primary reasons that I decided to study music therapy is because I have a cousin who is a year older than I am who has Down syndrome, and throughout my life I have helped to take care of him and have grown with him and helped him go through life. One of the major difficulties he has in life is that he can't really communicate specifically verbally. He has improved as life has gone on, but that is a major struggle that he faces each day, that he's not able to say even simple sentences to request what he's wanting or what he is needing or feeling. My first practicum experience here at IPFW was with a 5-year-old girl who has Down syndrome, and it was the same situation with her, that she also was not able to communicate. And so as her student therapist, I was working with her through treatment to be able to improve those verbal communication skills, to be able to get her to just give simple answers to prompts that I would give that were relevant to what I was asking her to say and in a timely manner. I personally believe that being able to communicate your thoughts and your feelings and your desires is essential to be able to have a functional and best life possible that you can have. You face many challenges if you are not able to communicate. So I felt passionately about this topic of seeing how music therapy, which is my field, could improve these verbal communication skills in children, because if you're able to address it early on, your life is so much more improved. It's much more difficult, as my cousin, who is now 23, is facing now, that he did not receive the help he needed at an early age. He is very limited in what he's able to do now, later on in his life. And if it had been addressed when he was a young child, his prognosis would have been much better. So my research question was, are recreative music therapy experiences effective in improving verbal communication skills of elementary school children with Down syndrome? From there, I looked specifically at the elements of verbal communication is an increase in relevant verbal responses to verbal, vocal, and musical cues observed, and if so, to what extent, and is a decrease in response time observed, and if so, to what extent. I focused specifically on the relevant verbal responses and the response time because of the nature of language and communication and conversation. That if I were to ask you a question and you were to answer me in a completely unrelated answer, then no real communication and connection has been developed there. And on the same note, if you were to answer me, even if it is a relevant response, but there's a great delay in that response from me asking you the question, then that also hinders that connection and that communication. And so if those 2 elements have the process to begin to improve, then the element of communication itself as a whole can be moved forward. My hypothesis was based on my experience with both my cousin and my client that I worked with and all of the research that I looked into in the music therapy literature that is available, that recreative music therapy experiences would be effective in improving the verbal communication skills of elementary school children with Down syndrome through the increasing of relevant verbal responses to cues and a decrease in response time from the cue. There is very limited resources available on this topic, which was another reason I decided to focus on it, both in the literature as a whole and specifically in music therapy literature. It has not been widely studied of verbal communication skills in Down syndrome and music therapy itself and how effective it is in improving that, and I find that it's an important topic that faces many people that needs to be looked at further. So my study was a quasi-experimental research pilot study. I was able to work with 3 clients, which was the pilot study aspect of it, to see if further study was warranted. I worked with a convenient sample of elementary school children with Down syndrome. I, through the university, found a local music therapist who is board certified, had experience with recreative music therapy, and had an established rapport with her clients that she had 3 clients who fit within the age range of 5 to 12 who have Down syndrome, were able to verbalize and vocalize, but were targeted as having a significant impediment in their verbal communication skills, and she was working with them in weekly treatment. From there, we took 10 weeks of weekly music therapy sessions, and then videotaped them. She then sent me the sessions from the first week, which served as our baseline, a midpoint at the 5th week, and then the 9th weeks of sessions as the final measurement. Through these, they had been edited out that I only received the experiences that were recreative in nature. From those videos, Dr. Jackson and myself watched each clip independently of the 3 individual clients receiving their individual treatment sessions and took a numeric count of verbal responses to the therapist cues that then the clients made the response to the therapist cues. So these cues that the therapist could give could either be verbal, vocal, or just built into the music themselves within the experience, not in between the experiences, and we took these counts, just tallied them up to ensure that we were on the same page. From then, we took a timing in seconds of the latency period from cue to response. So when the therapist gave the cue, from the second the cues ended, we started the time to when the client then began the correct response, then the time was stopped. And this was then averaged for an average latency time for each session for each individual client over the course of treatment. We used the 2 data collectors in order to increase reliability, to ensure that I wasn't just missing all of my counting, and to help increase the reliability of our study. So my professors here at IPFW have always taught me that you don't understand what music therapy is until you experience it yourself. I was unable to bring in clips from my study because of confidentiality reasons. Working with children and disabilities is not an easy thing to get clearance on. So I have decided to bring the recreative music therapy experience to you all. So I would greatly appreciate it if you were to all sing along with me. Old MacDonald had a farm, E-I-E-I-O, and on this farm he had a cow, E-I-E-I-O, with a moo-moo here and a moo-moo there, here a moo, there a moo, everywhere a moo-moo. Old MacDonald had a farm, E-I-E-I-O. Old MacDonald had a farm, E-I-E-I-O, and on this farm he had a pig, E-I-E-I-O, with an oink oink here and an oink oink there, here an oink, there an oink, everywhere an oink oink. Old MacDonald had a farm, E-I-E-I-O. Wonderful singing, thank you. So within that experience, it was recreative because I am not the author of Old MacDonald. We didn't just make that up, so it was already pre-composed. And within that, you are all actively engaged in music making and you're singing along with me. So within that, the cue was both, I could have verbally prompted, what animal should we sing next? What sound does a cow make? I could have, if necessary, if it was individual, I could have physically prompted you by tapping you on the shoulder or on the knee, indicating it was time for you to give me a response. But I used instead the innate nature of the music, that you heard the chord that needed to be resolved, you heard the pause in the music, that you understood that there was a time for a response to be given. You both did wonderfully that you gave me relevant responses in an animal to the farm. But in sessions, I could have been given anything. I have sung many interesting things of what is on Old MacDonald's farm. And then the response time would have been the time it took between me waiting, pausing, and for you to give the response needed. And through that, communication and connection is begun. So after we watched all of these videos, these numeric count of the verbal responses could only be used descriptively to help make sure that both Dr. Jackson and I myself were on the similar page of the data we are collecting, that we are counting similar things as correct verbal responses. We could not statistically look at the number of verbal responses because it could not be controlled. Within treatment, specifically music therapy, the needs of the client must always come first. So we could not mandate to the therapist who is participating, you must give X number of prompts in each session and only that number of prompts to the client. Because whatever the client needed, that is what needed to happen. So how many prompts the client needed that day, that's how many they got. So it changed from session to session and from client to client how many prompts were given. So since we could not control that, it was used only as descriptive analysis. For the duration of the latency period, we took the average response times and put them into two-tailed paired sample t-tests to see how they related and to see the improvement over time. And a probability level of 0.05 was set. So the results of the statistic analysis that we did result in statistically significant results. From the baseline to the midpoint of 5 weeks, there was not a significant change in improvement in the reduction of the latency time, but there was, from the midpoint to the 9 weeks, a statistically significant result in reducing the time, as well as over the course of treatment itself from baseline to the 9-week period of an even more significant reduction in the response time, showing that there was improvement and effectiveness of the music therapy. So in conclusion, numerically, there was an increase in relevant verbal responses given by each client. For each of the 3 clients that was studied over the course of the 10 weeks, they did significantly improve in the number of correct verbal responses they were given. But again, we could not look at those because how many prompts were given changed weekly as well. And there was also numerically a decrease in average response time for each client over the course of the 10 weeks. Statistically, there was a decrease in response time from the midpoint to the final measurement, and there was a decrease in response time from the baseline to the final measurement, which helped to support the hypothesis that recreative music therapy was effective in improving verbal communication skills. Completely anecdotally, just watching the videos of these clients from the first week to the final week, it was amazing to see how they have improved, how much clearer it was to understand what they were saying, how more consistently they gave answers to the therapist herself. I believe that this is an effective method for improving and working towards this problem, and that further study is warranted, possibly with a larger sampling population and more therapists and more data collectors in order to see how effective and help really work to help resolve this problem, because this is a difficult situation that many people deal with in their everyday life, and there's not many options out there for helping them. So thank you.
So you mentioned that there are only, I can't remember the number, 7,000 plus music therapists in the world.
Yes.
So so it is in demand, obviously.
Yes.
But so we don't have that many music therapists.
Correct.
So how do you increase the number of music therapists? Since we have a good number of children with Down syndrome in the world?
Well, yeah, no, you're fine. That is completely part of what we are taught here at IPFW. Is a big part of my career will always be explaining to people what music therapy is. And encouraging people to use music therapy and show the merits of it. We were only began as a career back in the 50s, and so in the 60s, so we are very new. And so it will only increase with the number of music therapists in time. As people find out more about it, they will hopefully begin to go to school and study it as themselves. I am sure everyone in this room has had some kind of impactful experience with music and has had some kind of connection with music. And it's so people who are inclined to be a helping professional and work with people and then have that connection with music and understand that power of music, if they find out about the career, they might be able to study it, and it's only through that it would be increased. I was lucky enough, my cousin has a music therapist, and so I shadowed her, and that's how I got into the field itself, because I saw what it was doing for him.
So, but there isn't that much awareness out there of the existence of, of music therapists that deal with situations like this. So how, is there something that would allow the music therapist to kind of increase more awareness and more show the demand?
I mean, it's doing things like this, just getting out into the world and the community, talking to people, showing people. So with Down syndrome specifically, here in Fort Wayne, in the area, there's DASANI, which is the Down Syndrome Association of Northeast Indiana. So going and talking to groups like that may not be aware of music therapy, and just showing families and the caregivers of children and with Down syndrome that this is another possibility to pursue. Yeah.
Did you attempt to try different kinds of music or instruments to see if there was a greater response to them, like different meters or something other than guitar? Or I was just wondering if you tried
the treatment planning and the experiences were all chosen by the therapist who participated. I did not have control over that, but within the clips that I studied, she did use a variety of music. She did use a variety of instruments. She used guitar, she used drums, and some other percussion instruments such as egg shakers, and then she sang throughout, and it was all different vocally.
Did any of those stand out as being more effective, like faster songs or slower songs, or something with guitar versus something with drums?
It depended on the client. Really, some clients responded more to the drums, some clients responded more to the guitar or the ukulele, and it also depended on the day of what the client was more interested in that day. Yes?
I think you did a really nice job here, and obviously the study that you did was very limited. It's not your fault at all, but this is kind of my point, is that it was very limited. There were only 3 clients, only 12 sessions, this kind of thing. And I'm sure that the research clearance for this kind of thing has got to be really, really tough. So what I want to say is that you did a really nice job of outlining your research design, acknowledging the limitations, being modest in presenting your findings. That being said, if you could design your ideal study of this, and let's also say you didn't have to worry about research clearance issues, okay? But if you could just study and really learn what you wanted to learn from this, what would it be? I mean, obviously increasing the number of clients, would be a huge thing. But I mean, are there other things that you would love to learn about this if you could sort of have some kind of unlimited budget and resources to really figure out what's best in this situation?
I would love to look at all aspects of verbal communication. Dr. Jackson told me I had to be more specific.
Well, she was right.
She was, but I would love to see all the aspects of verbal communication and communication as a whole. There is a lot of study out there of articulation and just the verbalizing and vocalizing itself, but that can only take you so far if you don't know what to do with those things. And so I would like to see what can be done with all aspects of verbal communication, all areas of music, all the methods of music therapy, certainly more clients and a longer time with populations like developmental disabilities. Part of their impairment is in the learning process, and it takes them longer to understand and to develop new skills and to require the new information. So this was a limited study for only 10 weeks, so being able to see over 6 months or over a year the progress that was made would be even more significant.
Are there ways of doing it apart from just counting, or counting a elapsed time, or I mean, would there be ways of like evaluating the quality of a response? I have no idea. I'm not an expert in this at all.
Yeah.
But I'm wondering, if there's ever been any research done in your field on that kind of thing, in a more elaborate kind of study.
The studies that I looked into, there hadn't been anything specifically done on what I was looking at. There was some closely related, but nothing specifically at what I was looking at. The difficulty with like quality of response is each person is different. And within the 3 clients we watched, being able to understand what they are articulating is different. The level they are verbalizing is completely different. And each person's skill level is different. So what what the therapist was looking for, even if she used the same experience for 2 different clients or all 3 clients, what she knew they were able to verbalize and vocalize is different. One person, maybe they could only give a desired vowel response, and that's where she was at with them. Another person might be able to give a whole phrase and creatively give it themselves without having to be told, this is the response I'm looking for. So it really depends on who you are working with, and it's a very diverse field, which is part of the complications with it.
Yeah, that makes sense.
So, and I apologize if I totally missed the slide if you showed it. Were the 3 clients that you worked with, were they all on the same level with Down syndrome or no?
All 3 clients did have Down syndrome. I was not provided specifically with their diagnosis and all their background and all that, so I can't speak on that. They each presented different ability levels. They were similar in nature, but they were in no means 3 identical cases. But within those 3 individual cases, they all showed their own improvement over the course of the 10 weeks, but they could not be compared to each other because they were different cases. Yes?
Sorry. First of all, this is amazing research, especially within the field of music therapy and students with disability. I've done a bit of research with students with disability, so the clearance level for the research really there's a lot of paperwork with it. And so you did a really, really good job. My question especially, just for you wanting to go into the field, do you think it would be, in your opinion, do you think it would be more effective or productive if you were to work with just one particular child or student that rather than 3 or 4, even working with 3, especially because they've got different skill level, especially just developmental levels are also different. Is it more effective to just work with one student and see their progress over time, or is it better to work with 3 and 4 and then just see their how the therapy is affecting them collectively over time?
From a research standpoint or from a treatment standpoint?
A little bit both.
Well, from a treatment standpoint, if I only worked with one client, I wouldn't have a job. It is, and that's one of the unique things about music therapy is we can work with numerous clients, and it's been shown to be very effective to we do group music therapy, and because of the nature of music, we are able to work with the whole group, and I'm working on different specific things with each individual person that they need, even though I'm using one song. So even though the therapist was working with 3 separate clients, these were individual sessions, she was only working with one client at a time. And she used the same experiences most of the time between clients. What she was able to work on with each client was slightly different, but with the same overall treatment goal because there is some generalization between that. Many people need to work on verbal communication skills in Down syndrome, that's the point. But from a research standpoint, it could be interesting to follow a single person throughout their whole treatment process for a while. It just really depends on from what angle you're taking it on from treatment. I chose to look at a larger group just to see how effective it could be even within multiple people and within the large variety that exists in special needs children.
All right, thank you.
Thank you.